Good morning, everyone. I'm Terry Dermody. It's a pleasure to welcome everyone to Pediatric Discovery Day. It's a terrific opportunity to celebrate science, truly in all of its forms, whether it's community partnered research or work done in the laboratory. All of this research is vital for our mission at UPMC Children's Hospital, and we're really grateful to be able to celebrate discovery today. Now, before we introduce our keynote speaker, I just wanted to express a couple of words of gratitude. First to Noelle Zuckerbrand and Colleen Kelly for organizing the Grand Rounds meeting all these this entire academic year, and very grateful to them. And then I want to thank Becky Chaffee, Shelley Hart, and Carl Bates for organizing Discovery Day. And I want to say a special thanks to Carl on this occasion of Discovery Day, because as many of you know, Carl is retiring at the end of June. And we'll have a chance to laud his many accomplishments as Director of the Division of Pediatric Nephrology, Vice Chair of Basic Research, and Training Director of our K-12 and T32 programs. But I wanted to just thank Carl for all of his hard work and support for science and scientists on this occasion of Discovery Day. And thank him especially for developing the concept of Discovery Day so we could all gather together and celebrate discovery. Carl, thanks a ton. And now I'm going to turn over to Carl, who's going to introduce Stephanie Davis, our keynote speaker. Stephanie, thanks for joining us.
Thanks for those kind words, Terry. Thank you. So it's really my pleasure to introduce today's keynote speaker for Pediatric Discovery Day and our Grand Rounds lecturer, Dr. Stephanie Davis. So Dr. Davis started her journey getting her bachelor's in biology at UNC Chapel Hill, and then got her MD at Wake Forest, and then went to Indiana at Riley Children's for her pediatrics residency and pulmonary fellowship. She then joined the faculty at UNC as an assistant professor of pediatrics in 2006, and then was promoted to associate professor with tenure in 2011. And she obtained some leadership roles while there, including the Pulmonary Fellowship Director, as well as Division Chief of Pulmonary. And she was there through 2011. And then in 2011, she decided to go back to Indiana at Riley Children's and was appointed as Professor of Pediatrics with tenure. She was the Division Chief of Pulmonary Medicine and the Vice Chair of Clinical Affairs in the Department of Pediatrics. Then in 2018, she decided she missed UNC and decided to go back there to become the chair of pediatrics. So looking at her CV, there's so many awards, and there are too many to enumerate here, but some of the highlights would be AOA while she was at residency or medical school, election to the Society of Pediatric Research, election to American Pediatric Society, and then later served as president of the SPR, which is really where we got to know each other, and is the recent past president, has done such a fantastic job with that society. She's had nearly 120 peer-reviewed original research articles, and then 20 national, international guidelines, recommendations, consensus statements, numerous book chapters and review articles, over 100 published abstracts, and has given numerous regional and national, international invited lectures, including Grand Rounds, which is why we're lucky she could fit us in her schedule. She's been a mentor to so many trainees. My count was 43, I might be off a little bit, students, residents, fellows. She served on 4 scholarly oversight committees, PhD thesis committees, has such an impressive record of NIH and foundation funding to support her research program, and has done service on so many levels, including such an impressive amount of national, international service on committees, grant review committees, peer review journals, and lots of local service to boot. So her research focuses on elucidating early pathogenesis in lung diseases, specifically cystic fibrosis, primary ciliary dyskinesia, and chronic lung disease at prematurity, as well as developing novel endpoints which identify and predict disease processes at earlier time points during preschool and infancy. And we're really lucky today to have her talk about unmasking the face of childhood suppurative lung disease. Dr. Davis, welcome.
Thank you. Thank you so much, Carl and Terry, for your really exceptionally kind introduction. I wish I could be there in person. And I have to say, Carl has been phenomenal to work with on SPR, just fantastic. So I'm going to share my slides and we're going to go ahead and get started here. we were practicing the video, so let me go back here to the very beginning. So today I'm going to discuss, the title of my presentation is Unmasking the Face of Childhood Suppurative Respiratory Disease. And I'm really excited to present to you and really highlight the importance of studying rare disease. I'm specifically going to be focusing on rare lung disease, but why I have loved being a physician scientist and really participating in discovery. These are my conflict of interest. I have grant support from the NIH and the Cystic Fibrosis Foundation, and I have worked closely with Perion Sciences and Recode Therapeutics in regard to therapies in primary ciliary dyskinesia. I will not be highlighting that today. So the objectives today are the following. First, to describe the pathophysiology and clinical features of early lung disease and cystic fibrosis and primary ciliary dyskinesia. Discuss diagnostic tools in primary ciliary dyskinesia, review genotype-phenotype relationships in primary ciliary dyskinesia and cystic fibrosis, and finally, really contrast these features across PCD, cystic fibrosis, and primary immunodeficiencies. So what is a rare disease? The NIH Office of Rare Diseases states the following, that it affects less than 200,000 people in the United States. And we know that about 7,000 rare diseases affect 25 to 30 million people in the United States and greater than 300 million worldwide. If you're the patient, here you may say, I'm the only patient with this disease ever seen by each physician I see. I am tired of being interesting. If you're the translational investigator, this is an opportunity to learn about biology. We know that in cystic fibrosis, the incidence is somewhere between 1 in 2,500 to 3,000. And in primary ciliary dyskinesia, we have historically stated that it occurs in about 1 in 16 to 20,000. But I'm going to show you some more recent data that states that it may be more prevalent than we originally thought. And you can see here primary immunodeficiencies and their incidence of 1 in 2,000 to 1 in 10,000, depending on which immunodeficiency. Asthma is much more common. Cystic fibrosis occurs in one gene. There are more than 1,700 mutations, and it affects the CFTR, our cystic fibrosis conductance regulator protein, which is responsible for ion transport. And we're going to talk more about that in a few minutes. Primary ciliary dyskinesia, we now know there are more than 50 genes. There has been an explosion in genetic discovery over time in all these rare diseases, and this has really helped in diagnosis, especially in primary ciliary dyskinesia. In PCD, we see that it affects the assembly and functioning of modal cilia. Primary immunodeficiencies, more than 400 defined mutations in more than 300 genes that affects components of humoral and cellular immunity. I'm going to spend the majority of this presentation really focused on CF and primary ciliary dyskinesia, but at the end, I'm going to talk about some of the overlap we've seen in primary immunodeficiencies. As I stated in the previous slide, we do think that this recent study has shown that the estimates of PCD, where we thought it was 1 in 16,000 to 1 in 20,000, that in fact it may be more common than we thought. This study published by Will Hanna and Ben Gaston this year in Lancet Respiratory, where they took 2 databases and they basically screened the genetic sequences of 180,000 unique people for disease-causing variants and 29 genes linked to primary ciliary dyskinesia. And they also looked at all of the genes that is known to affect PCD. And what I really want to focus on here is that what they found in this recent study, that in fact PCD may occur in 1 in 7,500 people versus 1 in 16 to 20,000. The other thing that was really interesting in this study was that it was more common in the Black and African American population than we thought, where it is occurring in 1 in 9,000 or 1 in 15,000, depending on the number of genes that you look at. In our consortium studies, we have not seen that. We have seen that it has been more prevalent in the Caucasian population. So there may be a bias in who's been participating in our research studies. On top of that, you can see that depending on your ethnicity, there's significant heterogeneity in the different types of PCD PCD genes that have been seen. So this is a really important study and highlights that, in fact, we are likely underdiagnosing this rare disease. So we know that more than 25 million Americans have a rare disease. As I stated earlier, 7,000 rare diseases. And when patients, families are in search of a diagnosis, they on average see about 8 physicians. They get many misdiagnoses. And it takes about 7.6 years to get an accurate diagnosis. And what can occur during that time are certainly depression or anxiety or stress associated with getting the diagnosis. And unfortunately, once you find the diagnosis, there's not a guarantee for a treatment. So this can be the way the families may feel. This is extremely difficult for families, which is why it's so important to get involved in rare disease if you're interested, and the importance, again, of discovery. So now we're going to dovetail into early lung disease, which is something I've spent the last 20, 25 years really focused on, and focus and talk about CF and primary ciliary dyskinesia, the importance of diagnosing disease early, as well as the challenges. It's important to diagnose early because you can ultimately change the trajectory of disease. So, for example, lung function is pretty much set by 5 years. We know it tracks over time. If we can get in early and intervene, we can prevent bronchiectasis, progression of disease. The problem is that often symptoms are not there, they're clinically silent, or they seem like dericarditis, and it's difficult to identify and especially monitor disease in young children. So identifying and treating early lung disease may prevent permanent and or progression of lung damage. So we're going to start off with early cystic fibrosis lung disease. How does it begin and when does it start? And this is really what I started doing in my early career, was assessing early CF lung disease. But just for the residents, just to go through what the basic defect in cystic fibrosis. We know that cystic fibrosis is a defect in the CFTR protein, that it affects the chloride channel. And we also know that there are 5 to 6 classes of cystic fibrosis. 1 to 3, class 1 to 3 are considered severe, and class 4 to 6 are considered mild. And these are more where your pancreatic sufficient patients are. And for class 1, for example, there's absolutely no functional CFTR protein. And for the residents, often the genes will end in X. For class 2, this is where there is an accurate misfolding of the CFTR protein. It never makes it to the cell surface. This is where F508del mutation sits, which is the most common mutation. In class 3, the protein gets to the surface, but there's defective channel regulation. So an example of that would be G551D. And then you see here 4, 5, and 6. In 4, you have decreased chloride conductance. 5, reduced synthesis of CFTR. And then 6 is decreased stability. And you can see here at the bottom of the slide the different specific mutation examples. We know that because of the defect, you have hyperabsorption of sodium, you have decreased secretion of chloride. And what happens is that leads to an inadequate surface hydration or decreased airway surface liquid. So you can see here N is normal and CF. And in CF, you have a decreased ASL or decreased airway surface liquid. This then leads to impaired mucociliary clearance, enhanced mucus adherence to airway surfaces, significant infection in those airways, as well as increased inflammatory response. And this cycle ultimately leads to bronchiectasis. The clinical manifestations are listed here. We know it's a multi-system disease leading to chronic sinopulmonary infections. About 15% of patients have meconium ileus. Pancreatic insufficiency occurs in 80 to 85% of patients. Patients can have recurrent pancreatitis. We are seeing definitely an increase in diabetes, which we start screening at about the age of 10, as well as male infertility. So when does it actually start? So I want to start off with a quote from a mother of a young child with cystic fibrosis. And she states the following: My daughter Emily was diagnosed with cystic fibrosis. In that moment, my professional and personal worlds collided. The most pervasive emotion I felt was the whisper in my heart that everything had changed. Several moments into the conversation, our pulmonologist pulled her chair alongside me, took my hands in hers, and told me that my daughter was going to live a long and full life, that it was her job as a physician and mine as a parent to help enable that. Because what parent can absorb hours of information when a voice is whispering in the back of her head that one day she will have to bury her child? So these were quotes written in a book that we wrote, and we had different families write about different things throughout the book. And it just highlights what these parents are going through and families are going through when their child is first diagnosed with cystic fibrosis. But it has truly been a miracle what has happened over the last 20 to 30 years in treatment of cystic fibrosis, because now we have so much hope for these families. But what is really important as we start off is that we identify disease early. So one of my first projects when I was a assistant professor was conducting a multi-center 10-center study measuring infant lung function across 100 infants at these 10 centers and seeing if in fact there was a longitudinal change in lung function and if they had evidence of early airway disease. And you can see here, we measure a forced expired volume in 0.5 seconds because infants don't blow out for 1 second. And red here is the cystic fibrosis infants, and the X's are healthy historical controls. And you can see that certainly there was a decline over time in FEV0.5. And RV over TLC, which is a measure of air trapping or hyperinflation, was significantly elevated in these children with cystic fibrosis. So this was only 2 of the sites of the 10 sites at this time were doing newborn screening, but we certainly know that there's evidence of early disease in this study. More recently, I worked with a fellow, Heather Mustin, who published this at Riley. And what we did was we looked at 45 infants with cystic fibrosis at 12 to 24 months of age, and specifically measured infant lung function and looked at their respiratory rate. These children would have been diagnosed through newborn screening. And you can see here that in fact, when you look at their Z-scores, that the abnormalities noted in these newborn screened diagnosed infants were the following. FRC was elevated at 2.18, so significant elevation with indicative of hyperinflation. FVC was slightly diminished. But I think one of the things that was most interesting was that the respiratory rate was elevated. And the reason I bring this up, to do infant lung function testing requires sedation and specialized equipment. I'm not going into how you actually measure it today, but it does take quite a bit of time. And because of that, it is better to get a more non-invasive way of in finding early disease. And in this study, we showed that in fact, the respiratory rate is elevated in these infants. And that's a really easy way to measure evidence of disease. Another tool that we're doing a lot of work on, and you're doing a lot of this work in Pittsburgh, is looking at multiple breath washout and the lung clearance index. Because spirometry has been less sensitive to early disease and cystic fibrosis, this is a tool that's being used actually clinically in Europe now, not clinically in the United States, but is being used as a research tool in cystic fibrosis. And the way this works is the following. Here you have, this is a preschooler. She's simply tidal breathing through this mask with Charles Clem, who's a respiratory therapist. This is from Riley. And you can see what we do here is she breathes in 100% oxygen to wash out the nitrogen all the way down to about 1/40th of the original concentration here. And then what we measure is something called the lung clearance index, which is basically the cumulative expired volume over FRC, or functional residual capacity. And so, in other words, if you have a lot of airway obstruction, it's going to take a lot longer to get that nitrogen down to 1/40th of that original value. And the elevation in LCI is indicative of ventilation inhomogeneity and really is a better measure of peripheral airway disease. So we know that the lung clearance index is sensitive to early disease and cystic fibrosis. This was a study that we participated in with Toronto, where we looked at 156 participants, cystic fibrosis and matched controls, and certainly showed that LCI was significantly elevated here, as you can see here, in the cystic fibrosis patients compared to the healthy controls that are in these, the white diamonds. The other thing, this is a technique that preschoolers are able to do. We also know that LCI was stable in our healthy control group here, but increased, here's the healthy control group, but increased with age and cystic fibrosis. So you can see that LCI increased in that preschool age between 3 to 5. FEV1 was lower in CF, but the rate of change was no different in the healthy controls. So this was the same study I just showed earlier, and we looked at it in that cohort. We've continued to follow that cohort and recently published this data. Again, Lucy Perron, who is in Toronto, led this. And you can see here, we know that LCI actually tracks respiratory events. But don't throw FEV1 out too quick. It still provides important data. So here you have FEV1% predicted and the relative change in LCI on the y-axis. Here's baseline. You can see that FEV1 drops, LCI increases with symptoms as would be expected. And after treatment, that LCI doesn't completely go back to baseline and FEV1 doesn't completely go back to baseline. Improves, but not quite back to baseline. What you see here is that 32 infants had a worse LCI and FEV1, 43 had worse LCI, and 22 had worse FEV1. So really, both of these measures may be important in assessing disease. So let's move to structural lung disease and talk about the early evidence of structural lung disease. This is a 2-year-old with cystic fibrosis that has significant bronchiectasis. Again, this is a child who I saw many years ago at UNC. And you can see here, when you look at the percent of lung affected, and this is through what we call pragma scoring, which is specialized scoring to look at evidence of disease, that 3 months to 2 years, 3 to 6 years, and 7 to 16 years, there is evidence of bronchiectasis very early in these children. And in this study, this is a Australian study, 20% of patients, in fact, had evidence. It may not be a lot, but they had evidence of bronchiectasis. We also looked at this through an early CF study that we did at Riley, and this is D.B. Sanders, who's currently this manuscript's in revisions, and we've been looking at this. And basically, I want to highlight the importance again of early respiratory symptoms. They should not be ignored in cystic fibrosis. Here you see airway wall thickening and total airway disease. This is through subscores of that special scoring system called pragma. And there's significant correlation with cough and wheeze, and so and atelectasis as well, and really highlighting that, in fact, when you have lower respiratory symptoms, you want to take it seriously and think about treating. Okay, great. So Stephanie, you're telling me that we have early disease. It's hard to detect. There are some methods that we're working on to better detect disease, but how do we actually treat early cystic fibrosis lung disease? So now I'm going to talk about a study, about 3 studies that we did looking at hypertonic saline. So as you recall, we talked about that in cystic fibrosis, there's depletion of the airway surface liquid by giving an osmotic agent like hypertonic saline, that in fact, that increases your airway surface liquid and in fact may improve mucociliary clearance. This has been shown to be effective in older patients, and I'm going to show some work that we did over the last 10 years looking at infants and preschoolers. The first study we did, which Dr. Weiner, who participated with us in Pittsburgh, was heavily involved in this study, was the infant study of inhaled saline. It had an absolutely horrible acronym, ISIS. It was an acronym that we used before there was an actual ISIS, so I don't show the acronym anymore, but this was our study design. This is a 30-center study. Well, it was a randomized controlled parallel group trial. We had children with an established diagnosis of cystic fibrosis between the ages of 4 to 60 months of age at enrollment. And we gave the children either 7% hypertonic saline twice a day or 0.9% isotonic saline twice daily for 48 weeks. Now, what you see on your right is pulmonary exacerbations, and if there was a difference, and in fact, we did not see any differences in pulmonary exacerbations between the hypertonic saline and isotonic saline group. This is very disappointing because this was our primary outcome measure. However, What we did see was that in our physiologic measures, that hypertonic saline, in fact, did show a difference in FEV.5, which is again an infant lung function measure compared to the isotonic saline group. So hypertonic saline was favorable from an FEV.5 perspective. So this is our physiologic measure. And then in Toronto, they were able to measure lung clearance index in infants and preschoolers at that time. And they also showed that LCI improved. It diminished with hypertonic saline compared to isotonic saline. So this told us that, in fact, physiologic endpoints were better to use in efficacy studies in young patients, potentially, because we didn't see a change in pulmonary exacerbations as had been seen in older patients and school-age and adults. So what we then did is moved on to another study called SHIP, which is a saline hypertonic study in preschoolers. And we looked at LCI in these preschoolers and showed that, in fact, LCI significantly improved with hypertonic saline over a 48-week period. And we published this in Lancet Respiratory, and really showing that hypertonic saline may in fact be something to consider in these younger patients for treatment. We then just published this data in Lancet Respiratory. This is something we worked with our European colleagues and Australian colleagues. Harm Tiddens was the lead author on this, where we looked at hypertonic saline and isotonic saline, and we looked specifically at pragma-CF. This is chest CT scores in cystic fibrosis, and you can see that with hypertonic saline, the percent disease diminished. We saw less bronchiectasis in our hypertonic saline group over 1 year compared to the isotonic saline group, and percent trapped air was significantly lower in the hypertonic saline group compared to the isotonic saline group. This is actually the first study where in preschoolers that has shown that, in fact, we can see a difference in structural disease with treatment for cystic fibrosis. Again, potentially this will help to change the trajectory of disease for these children. So let's move to early primary ciliary dyskinesia. What do we know about that? How does it begin and when does it start? So let's just quickly review PCD pathogenesis. We know that in PCD, with your cilia, that your cilia beat frequency should be somewhere between 10 to 15 hertz. We know that the ciliary axoneme is a highly conserved structure composed of over 250 proteins. As you recall, the cross-section of the cilia here, 9+2, where you have the 9 outer doublets and the central microtubule, your radial spokes. Now in PCD, what can happen is you can have a number of different issues throughout the cilia, including in many of these proteins. This is just more of a cross-section a little bit closer up, where you can see the radial spoke, the inner dining arm, the outer dining arm, the doublets, the central complex, the nexium weak. And these dining arms are composed of heavy, intermediate, and light chains. The ultrastructural defects in primary ciliary dyskinesia are the following. You can have absence or shortening of the outer dining arm, absence and shortening of the outer dining arm and inner dining arm. You can also have absence of inner dining arm and complete microtubular disorganization, which you see here. Or you can have absence and shortening of the inner dining arm, but that requires 2 to 3 biopsies to confirm the diagnosis because there's often false positives, and you can have central complex defects here. So absent outer dining arm, both arms can be absent, absent inner dining arm microtubular disorganization, or absent inner dining arm alone. So let's just look at what normal cilia function looks like. So if you have normal mucociliary clearance or normal cilia function, this is what it looks like. The cilia beat in a coordinated fashion, and somewhere between 10 to 15 hertz. In PCD, this is what it looks like. Discoordinated beating. Clearly, I think it's pretty obvious from this slide that this patient is going to have ineffective mucociliary clearance in their airway. So there's been explosions of gene discovery in primary ciliary dyskinesia since 1999. The first gene identified was DNAI1, We now have over 50 genes identified, and you can see the different years and all the different genes that have been identified. Muna Zarawala is our geneticist who works with us here, and this has been an important part of what we've done here as part of a consortium and here at UNC. And also there's been a lot of international work. We've worked with a lot of international colleagues to help identify these genes. So here you see a highlight of PCD genotype and phenotype. You can see here where outer-dining arm alone defects, the outer-dining arm structural proteins, and all the different genes associated with that. Specifically focus here on the inner-dining arm and microtubular disorganization. That's associated with CCDC39 and CCDC40 genetic mutations. Here's outer-dining arm and inner-dining arm defects. Inner-dining arm alone, we do have a gene identified with that. That is a fairly recent thing. And a lot of patients have completely normal ultrastructure, but they can have a number of defects here, genetic defects, which you see here. The radial proteins, you should start with RS, and you can see a number of those. Here we have EMs, which we really haven't completely identified, but these are the genes. You can also have very little cilia, oligocilia. Those are seen in like CCNO, Makaitis, and FOXJ1, which is an autosomal dominant trait. And general PCD is autosomal recessive, though we do have some patients who have autosomal dominant trait like FOXJ1, or this X-linked recessive traits, which are associated with other syndromes. The blue on here are the patients, if you have these defects, you have situs defects, so you can have situs inversus. The green, we don't know the situs. You can see in the radial spoke or central apparatus, those patients do not tend to have situs defects. So this just really highlights, remember PCD being a rare disease, but how difficult and more rare it becomes if you're one of a patient that may have one of these more or less common genetic defects. DNH5 in general has been the most common genetic defect. So when does PCD start? I really like to highlight this study. This was done out of Toronto. This is Sharon Dell, and she led this study. This is a study where they recruited 46 subjects with primary ciliary dyskinesia and 46 controls. And you can see here, PCD cases and control subjects. And the thing I really want to highlight is that these patients with PCD were on oxygen in the NICU for much longer than the control subjects. That the duration of oxygen therapy was much longer, up to 15 days compared to 0.8 days in the control subjects. So these patients may be term babies that present with neonatal respiratory distress. You keep wondering, why can't I wean the oxygen off of them? They end up on oxygen. We've even had some children on it as long as 90 to 100 days. They definitely can present. In fact, about 80 to 85% of patients will present with PCD, with neonatal respiratory distress. The other thing Sharon showed is their x-rays. Now, if they have situs inversus or dextrocardia, you're going to be more likely to think, oh, this patient may have PCD. But 50% of those may not, but they can have this upper lobe collapse. So these atelectatic areas, and that was much more common in the PCD population. So consider primary ciliary dyskinesia in neonates that are term with respiratory distress, prolonged oxygen requirement, and who have lobar collapse. And certainly if situs inversus is present, the possibility increases. We published this in the Blue Journal in 2015, and it really shows the symptoms that we see in primary ciliary dyskinesia. Chronic cough occurs in 99% of patients, and the age of onset is very early at about a month of age. Chronic nasal congestion occurs in 97%, chronic otitis media in 92%. The age of onset of nasal congestion, again, is about at a month of age. These children are having a wet cough every day that might improve with antibiotics, but not resolve, and they do it throughout all 12 months. It is not seasonal. You can see here the supplemental oxygen use at birth that we just discussed, the laterality defects as well. So Margaret Lee published this in 2016, where we were looking at how do you define the phenotype? And one of the most important things for diagnosis is to first define if it fits a PCD phenotype. And what she showed is that these four features, unexplained neonatal respiratory distress, early onset year-round wet cough, early onset nasal congestion, and laterality defect were the 4 clinical features that were increased the risk of having primary ciliary dyskinesia. And certainly if you saw all 4 of these, that would really be a signal that this child may have PCD. Interestingly, multiple ear infections did not, which is because we see this a lot in other children. So this was not a good differentiator. We also know that on chest CT, patients can have significant bronchiectasis, and they look just like this, where you have this lobar distribution of it. And you can also see from this study from Kennedy and al. That in fact, this is all adults and children. And that in fact, these patients have significant lobar distribution of disease in the right middle lobe, the lingula, and the lower lobes, which is a little bit different in cystic fibrosis. We tend to see it a little bit more in the upper lobes. So Bree Kinghorn has been working on a study where we had collected chest CTs over a 10-year period in children with cystic fibrosis as part of our consortium. And this Melbourne Rotterdam annotated grid morphometric analysis for PCD, where they've looked at atelectasis, bronchiectasis, mucus plugging, and bronchial wall thickening. This is a 9-year-old with PCD, but just shows the different components that are part of this scoring system and what we've been analyzed. This was all analyzed in Rotterdam with Harm Tiddens, who does a lot of work in this area, not only in cystic fibrosis, as we highlighted earlier, but also in PCD. And you can see here that patients who had the inner dining arm microtubular disorganization, that in fact, they had more mucus plugging compared to other ultrastructural defects, and they had just more disease compared to patients with other ultrastructural defects. So in fact, we do see ultrastructural differences in regard to disease. I'm going to show some more data about that, and that there is significant disease in these young patients structurally. And I did want to highlight just infection. PCD patients tend to have similar infections as cystic fibrosis. This is also part of our longitudinal study where we had 137 patients with confirmed PCD. We saw them at 5 annual visits. We had respiratory cultures. These patients tend to expectorate sputum much easier than patients with cystic fibrosis do. And we do see Pseudomonas aeruginosa in these participants. We saw them in 40 to 100 of the 37 participants, but it tends to come and go a little bit more often than what we see in cystic fibrosis. It was persistent in 13, and there were 4 who had mucoid. But here you see H. flu, staph, strep pneumonia, Moraxella, and Pseudomonas aeruginosa, and then the change over time, and Pseudomonas certainly increases over time. Their lung function is significantly heterogeneous. You can see here at 6 years of age, there are some children that had lung function as low as 60 to 70% predicted, and some that looked quite good. This was a study done out of Europe. We looked at it, again, measuring lung clearance index and FEV1, and found, in fact, Bree Kinghorn presented this, that in cystic fibrosis, where we have abnormal lung clearance index in 58% of patients, we had abnormal lung clearance index in 59% of PCD, and FEV1 was abnormal in some, about a quarter, but less common to be abnormal than LCI. So LCI, similar to cystic fibrosis, is more sensitive to early disease and primary ciliary dyskinesia. And finally, Bree Kinghorn also looked at this, and I think this is really something important to point out. In PCD children from our consortium, the longitudinal study, what we did was we took our consortium study, which had about 137 patients, and we matched them with CF children out of the CF registry. And we did a linear mixed effects model, and actually Bree Kinghorn and Margaret Rosenthal did a lot of this work from our consortium. This is FEV1% predicted. And you can see here in red is patients with PCD who have inner dining arm microtubular disorganization defects. Those patients tend to have worse disease. The blue is all the other PCD patients who had other defects. The black are children with cystic fibrosis who have a minimal, in other words, these are like your class 1, 2, 3. These are the more severe children with more severe mutations. And the green are patients who have more residual CFTR protein. And you can see here that in fact, patients with inner arm microtubular disorganization had worse disease compared to cystic fibrosis and patients with other defects. And then if you look at the mean FEV1 in 18 years, that those with PCD and the inner arm microtubular disorganization were sitting at 60% predicted, and CF actually had higher FEV1 values. This is a significant disease with significant morbidity. Here are some quotes from patients or families with PCD. It felt like I was crazy. I knew something was wrong. People kept telling me she was fine because she was growing okay. Families definitely feel this way because it takes so long to find the diagnosis. Here's another one. She spent a vast amount of time in the hospital, away from everybody else. She started school 3 months after everybody else. She does feel kind of segregated from everybody else. So let's move to genotype, phenotype, and cystic fibrosis. The age of CFTR modulators has been incredible, and I'm not going to spend a lot of time on that today because I don't have time, but just to highlight, there are many studies that have been published showing just an incredible impact of these modulators. And the most recent one, Trikafta, you can see here that the increase in FEV1 on the triple drug here, Trikafta, is unbelievable, where you have a 10 to 15% bump in FEV1 on these modulators. I mean, these patients are doing so much better. And here is just a table showing the different modulators, when we can start them, what genotype is associated with them. And we continue to increase these modulators and bring them down the pipeline. So there's so much hope in cystic fibrosis. And this is really because we're able to target the defect based on the CFTR protein defect and the genotype and treat those patients. So this has been an incredible team science approach to and working with Cystic Fibrosis Foundation, NIH, Vertex Pharmaceuticals, many CF centers to really make a difference in cystic fibrosis. As most of you know, any of the pulmonologists know this, but we don't hardly even admit children with cystic fibrosis to the floor anymore. It is incredible. And these are some testimonials from adults after starting Trikafta. I saw numbers I never thought I'd see again in regard to lung function. I cough a handful of times in a day instead of all the time. This pill doesn't cure me, but hope is no longer just a word. I'm thankful I get to experience this before the need for a transplant. In my lifetime, CF has gone from a disease that's cause had just been discovered, 1989 is when the gene was discovered, to a disease that is not going to be a death sentence. It's truly remarkable. And this is really highlights what a team approach can do in improving disease. Now let's go back to the quotes from that mom at the very beginning who came to clinic after her child was diagnosed with cystic fibrosis. 5 years later, she's the kindest, silliest, and strongest girl I know. She accepts that she has CF, but she's not defined by it. Emily's diagnosis has given me a fierce desire to control what I can control. The hardest part is navigating the outside forces beyond my control. I want her to live a full life without fear. I also want her to be healthy enough to benefit from the new therapies coming down the pipeline. If I could speak directly to other parents, I would tell them that it's normal to mourn the loss of the life that you thought you would leave. Parenting a child with CF will not be simple, but that doesn't mean your child can't live a long and full life. Let's pivot to genotype, phenotyping, and PCD. So this was a study published in the Blue Journal in 2014, where they looked at patients with RSPH1, these are radial spoke defects. And what they found was, in fact, patients with radial spoke defects have much more mild disease. That, in fact, their FEV1 is higher compared to all PCD patients, and higher compared to patients with outer dining arm defects, sitting at 73% predicted versus around 62% predicted. They also had less neonatal respiratory distress, so really more mild disease. And their ear and sinus disease was similar to other patients with PCD. So we know there's a heterogeneity in regard to how these patients present. We showed in 2015 in the Blue Journal that, in fact, patients with CCDC 39 and 40, which is associated with the inner dining arm microtubular disorganization defect, has worse disease. These patients are shorter, they weigh less, their BMI is lower, and their FEV1 is significantly lower compared to patients with outer dining arm defects. We also know that patients with intradyne arm microtubular disorganization present earlier. They're just sicker. So they presented about 2.5 years of age compared to these other patients with outer dining arm and normal ultrastructure. And this just shows the study here, where you see in the nice yellow fluorescent boxes that the patients with CCD C39 and 40 had much worse disease compared to the other patients with outer dining arm defects. So these patients have much worse disease, and we saw it also in our adult population as well. And again, this shows that longitudinally, we had followed it up over the 5 years, and there's a significant decline compared to the others, which are some are pretty flat. The mean annual change in FEV1 for the entire cohort is about minus 0.57%. I do want to highlight heterotaxy. Heterotaxy is more common in patients with primary ciliary dyskinesia. It's been reported to occur in about 12% of patients. This is a study we presented, and we're currently writing up this manuscript. This is being led by Drew Barber, one of our fellows. And you can see here that when we looked at the odds ratio of having a laterality defect in patients with different ultrastructural defects, and we used the inner dining arm microtubular disorganization as a reference group, that in fact patients with outer dining arm had a higher risk of having heterotaxy compared to those with inner dining arm and microtubular disorganization. So there's more evidence of situs ambiguous and situs inversus in these patients with outer dining arm. Now, patients with normal or near normal ultrastructure often have radial spoke defects, and those patients don't tend to have situs defects. And I did want to just briefly highlight, I'm not going to go through all the details on the slide, but Cecilia Lowe there at Pittsburgh does tremendous work on genetics and congenital heart disease, and has done a lot of work in primary ciliary dyskinesia as well. This is a study that her group published in PLOS Genetics in 2016, really showing the complex genetics in heterotaxy, where they looked at DNAH6 mutations in the dynein gene and how this, as well as other PCD genes can potentially cause heterotaxy. So great work from her group at really trying to understand heterotaxy. So we know that diagnostic testing for PCD is evolving. Ultrastructural defects only occur, you can only see them in about 70% of patients with PCD. And genetic defects can now probably detect 70 to 80% of patients. So do we have another test that can help us? Well, in patients with PCD, we can measure something called nasal nitric oxide, which is basically a direct measure of nitric oxide in the gas phase. Here you see one of our fellows who's now in South Carolina practicing pulmonary, but doing a nasal nitric oxide measurement. And we know that in primary ciliary dyskinesia for patients 5 and up, that in fact they have significantly low nasal nitric oxide levels here in red compared to the healthy controls in blue. Here our cutoff here was 77 nanoliters per minute. But let's talk about how using this adjunctive test may lead you down a false road. This is a patient that we saw, an 11-year-old with chronic nasal congestion and wet cough. 3 hospitalizations for pneumonia. Chest x-rays revealed persistent patchy infiltrates in lower lobes, pansinusitis, Klebsiella staph and strep pneumonia, and a significantly low FEV1 value with no bronchodilator response. So this patient was referred for evaluation for primary ciliary dyskinesia to UNC. This child had had normal sweat chloride testing, CFTR results, 2 mutations found, but in cysts, no ultrastructural defect. And the nasal nitric oxide was decreased at 9.8 nanoliters per minute. And 1 year later was also decreased. So we know that in PCD, NO is decreased. So we thought that this child had probable primary ciliary dyskinesia. The patient was in for a research study. The patient didn't return for follow-up for 2 years, reported having intervening atypical mycobacterium. A follow-up, when we did see them again, FEV1 much better at 101% predicted, significant bronchiectasis noted, and the nasal NO was much higher, really in the normal range at 117. So for the next 6 years, the family reported she was doing well, little to no call, 2 respiratory illnesses, easily treated. started college. Then she developed a sudden acute illness, hospitalized, tachycardia, thrombocytopenia, transferred to Mass General, underwent a bone marrow. Bone marrow consistent with hemophagocytic lymphohistiocytosis, EBV positive, later confirmed to have GATA2 deficiency, and died, unfortunately, shortly thereafter. So this is a patient who had a rare primary immunodeficiency, had phenotypic overlapping symptoms initially with primary ciliary dyskinesia, presented with low NO that ended up coming back up. And so it really highlights caution when using nasal NO. We also know that nasal nitric oxide levels during respiratory tract infections can diminish here in healthy babies, I'm sorry, this is in babies actually, and you can certainly see it diminishes in these babies. And we also know that in babies, nasal nitric oxide levels can be low in healthy and in PCD. So it doesn't differentiate as well in the younger age group. We also know that in patients with like RSPH1 that has a more mild phenotype and other phenotypes, that in fact nasal nitric oxide levels may be above the cutoff. So we're seeing more and more above the 77 nanoliters per minute for nasal nitric oxide levels in PCD. This is a study published by Adam Shapiro, and I really just want to highlight that patients with primary immunodeficiency can have low nasal nitric oxide levels that overlap with PCD, which is why it's really important to make sure you have the right diagnosis. And here you see compared to healthy controls. And this is a RAG1 patient where you can see significantly low nasal NO in this study. So finally, what have we done in regard to next steps to better understand this? As part of our Genetic Disorders and Mucociliary Clearance Consortium, this is a consortium that's been around for 18 years. Mike Knowles and Margaret Lee led it. Now myself and Tom Ferkel lead it. We decided to start to look at primary immunodeficiencies and the overlap with PCD. We know that there are a number of different genetic mutations and primary immunodeficiencies, many different categories. I'm not going to go into all of this today. Again, I'm not an immunologist. We're working really closely with our immunology colleagues as we do this, but we want to make sure we get the right diagnosis in these patients. And since there's so much overlapping phenotype, we have worked closely with our immunologist and added this into part of our study. And you can see here that when you look at just beside each other, PCD being rare, primary immunodeficiency being rare, you see the categories of PID. We know that in PCD there's abnormal ciliary biogenesis, but the clinical phenotype in primary immunodeficiency are very diverse, but some of the symptoms definitely have overlap with PCD, recurrent ear infections, upper and lower respiratory tract infections. So our studies are now looking at both of these populations. So the next steps for our consortium are to look at chronic suppurative lung disease and the overlap between PCD and PID. We in our consortium have diagnosed individuals with PID, and it's really an opportunity to leverage the consortium and our understanding of both of these rare disorders. These are our current projects. We're looking at suppurative lung disease in children and adults. We're also characterizing respiratory tract exacerbations in PCD. And we're characterizing upper airway manifestations in PCD and PID. This is our consortium and our site leads. And again, in rare disease, you need a large group, big team science to really study it. So finally, I'm going to end with this. In rare disease, it's really a synergy of clinical research, foundations, care centers, patients in the middle, always, and families working together to really, really dive in, understand the disease, make the diagnosis, understand the mechanism, and get the therapies there. That's why we do discovery. And let's end with these quotes. If I could speak to other care team members, I would tell them that above all, words matter. You don't need to be perfect, but you do need to see us as real families who are doing our best. Help us to address not just the clinical aspects of care, but the emotional aspects. Recognize when we're struggling. Tell us when we're doing a good job. Remind us not to build walls around our kids. Always remember that our children are more than cystic fibrosis. They're smart, strong, brave, and kind individuals who are doing their best to navigate their wonderfully chaotic journey we call life. In conclusion, disease begins early, may be silent. can be challenging to diagnose for rare lung diseases, and there's a wide range of presenting symptoms and severity. Phenotyping history is critical. A panel of diagnostic evaluations is indicated to confirm the diagnosis in many of these, like primary ciliary dyskinesia. Be cautious when interpreting nasal nitric oxide results and genetic reports. And with further advances in gene discovery, we expect to improve sensitivity of gene testing, more readily identify less severe disease, categorize patients into mild versus severe phenotypes, and expand targets for gene-based therapy. And this is definitely what we're really working on in primary ciliary dyskinesia right now. Genotype-phenotype relationships are emerging in PCD and have been critical in cystic fibrosis for the modulator therapy, and rare disease networks are critical to enhance our understanding. So in PCD, we're really at the tip of the iceberg, and in many rare diseases, that's the case. So discovery is out there, and for those of you who are interested in research, go for it. I think it's been fantastic, part of my career. These are my acknowledgements. It takes a village. I work with phenomenal collaborators, phenomenal team, and I've worked with many people at Pittsburgh, especially Dan, who's fantastic to work with and knows so much about early lung disease. And here you see Michelle Mannion and Chris, who both work at the Immune Deficiency Foundation, the PCD Foundation. But most importantly, our patient and families have been just incredible. So that is it, 4 minutes to spare. And I just finally want to thank Carl and Terry for inviting me. I wish I could be there. It's very sunny there in this picture. It looks beautiful. So I just want to thank you. It's really, really, really an honor to be doing this today. Take care. Thank you.
Thank you, Dr. Davis. That was a wonderful, wonderful presentation. I love the patient quotes. It really takes it home, right? Reminds us why we do all this. So before we take some questions, actually there are some questions in the Q&A. Please, if you do have questions, please post them in the Q&A. And just a couple of housekeeping things. So at the end of this, around 9 o'clock, we're going to flip over. If you want, there's a meet and greet. There's a separate link for that. That will be in the chat if you'd like to talk to Dr. Davis. And then for those that are engaged in Pediatric Discovery Day, there's a separate Teams link that came from Becky Chaffee. And if you don't have that, please, that starts right at 9:15 with our scholars that we'll be presenting. So let's see, there's an anonymous question. Dr. Davis, excellent talk. What cilia changes do you consider specific for PCD? Thank you.
What cilia changes? Well, the cilia is made up of so many different proteins. And so the cilia changes that are specific for PCD are a lot of what you see ultrastructurally, whether it's defects in the dynein arms, in the radial spoke, in the central apparatus, though you can also have cytoplasmic proteins that are defective as well. It's a pretty complicated disease. We also know that when cilia, when we look at beat, some patients with cilia beat can have round circle beats, they can have slower beats, or even more rapid beats and have primary ciliary dyskinesia. So it's a very complicated disease, and there are many different defects that can lead to cilia dysfunction.
So the second question is, I think it's related to the first. And maybe you answer this. Are the ciliary changes you describe pathognomonic for PCD?
The cilia changes I described from an ultrastructural perspective are pathognomonic for PCD, but what I will caution everyone is that it is challenging often to make these diagnoses through electron microscopy, depending on the expertise at the centers. Mayo does a lot of work in this area. We've done a lot of work here. What I have seen for a lot of PCD centers now, and as we move forward, is that we do genetics first, because we've identified so many more genetic mutations associated with PCD, that's really where we're going to first. Whereas in the past, we were doing more ultrastructural evaluations. And I did want to say, Carl, that I know that Mark Dovey and Dan Weiner are working on getting a PCD Center of Excellence there in Pittsburgh, which I think is fantastic. And you guys will be doing a lot of work in that area. So that's awesome.
So we probably have time for one more question. There are more in the Q&A, but so please feel free to come to the meet and greet where you can ask Dr. Davis directly. But the last one will be from Julia Lai. Have researchers used pragma scoring to track structural lung disease progression in PCD patients, like what you did in the SHIP CT study?
Great question. And the answer is not yet. We have the data and we're starting to look at it. So thanks, Julia. That's what we're doing.
Well, okay, so we're at the top of the hour. There are other questions, but as I say, I would ask you to click over to the link to the meet and greet, which is in the chat. And so we'll see. So thanks again, Dr. Davis, for a wonderful presentation. That was fantastic.
Thank you, Carl. I'm going to switch over now.
We'll
Bye,
see you.
everybody.
We'll see you all in the meet and greet.
Bye.